Thank you so much, Dr. Wael. Okay, I'm going to talk today about the orbital atherectomy. I have no conflict of interest. So we are dealing with our arteries or daily practice as this young, stubborn teenager. We have to prepare them. We have to clear things up when we are dealing with such situations. So along these years, we are talking about angioplasty. We are doing our procedures every day. We are aiming for something which is the visual compliance. We don't need to have target lesion revascularization after some time. We are avoiding the recoil. We are avoiding the dissection. So we are aiming for optimal visual preparation. And what is the optimal visual preparation? It's removing of the calcium, modifying the plaque, gaining lumen, less dissection, avoiding recoiling, and avoiding stenting. So this is a strategy of leaving nothing behind. And the old technique is the buba. We use it all the time. But before any attacking here, I'm not saying that it's old, it's obsolete. No, we are using buba every day on our daily practice. But it's proved that it's having an early recoil and dissection. So we are aiming for something different to change this maneuver for lumen gain, reducing the bail-out stenting, and probably improving the drug uptake. And that's why we are using the atherectomy devices. One of the devices in the market now, having different options that giving us those criteria, giving us calcium removal, improving the visual compliance, and also potentially increasing the drug uptake. So it's like something like removing something from your arteries. It's exfoliating only for arteries. And what I'm talking about today is the orbital atherectomy. Orbital atherectomy is when we are doing a standard angioplasty alone, as we said, it's not enough. Buba is not enough. So the visual preparation with finesse, including these devices like orbital atherectomy, and the component of this orbital atherectomy, it's composed of this Viper wire, Viper Glide advanced wire, having a high trackability and performance. So the main device component are the main bumping device, the glide assist, and the crown options. And when we are talking about the crown options here, can we go back, please? Okay, so we have three crowns here, three different crowns, the solid, the classic, and the micro. And the difference here in those crowns is they are giving us a lot of options, a lot of opportunity to have different maneuvers during the cases. When we are talking about the small vessels, the highly tortuous vessels, we are using the micro crown. When we are getting the maximum calcium removal, we are talking about the solid crown, and also in a certain area like common femoral artery or popliteal artery, we are using the classic crown. So how does it work? The main action of this device is a dual action. Its component is bidirectional ablates and sands. It's like sanding the calcium, and this gives a lumen and also giving a waves to the internal elastic lamina that gives us some potential advancement of drug uptake after using DCB following the orbital atherectomy. So it's improving the vessel compliance. Second is it's an easy maneuver and improving the ablation efficacy. So peripheral orbital atherectomy dual mechanism, as we said, it's a sanding mechanism and giving also a pulsatile forces, a low frequency pulsatile forces and the high frequency pulsatile forces. You have three different options in the glide assist that gives you an option during working to have more and more calcium removal. And one of the advantages also from orbital atherectomy in heavily calcified vessels is it's not occluding the lumen during work, like rotational atherectomy. No, it allows flow of the blood during the atherectomy work. It reduces the calcium through differential sanding and also improves the vessel compliance. There is also some situations you shouldn't use the orbital atherectomy, which is if you didn't pass, of course, intraluminally, if you have a sensitive graft, if you have acute thrombosis, frank dissection you can see, and in stent occlusion, it's not recommended to use the orbital atherectomy in such a situation. So I have a short case for this. It's a 67 years old male, diabetic hypertensive with cabbage 7 years before, and have bilateral RC5 heel ulcer, near total occlusion of B2 and B3, tibial trunk. So as we can see here, we can see the B2, B3 near total occlusion, small artery path. And after using the solid crown here, we can see easily busing in some areas, but also having a high resistance in some heavily calcified areas. And by the way, one of those cases, we didn't use the filter device, distal embolization protection devices. So after this, we proceeded for the posterior tibial artery, and I can see good blushing at the heel part. And this video only to show that it's easy maneuver. You can use the glide precisely while are using the controlling the device. And you can, as I told, it have 3 different grades of velocity that can give you maximum rotation pulse that can remove the maximum calcium. And one also of the advantage of the orbital atherectomy devices is you can go with one catheter from 2 up to 4 millimeters, so you don't need to change the catheter. So what is literature saying about the orbital atherectomy? One of the famous literature here is the Liberty 360. And at the result, we can see here that with orbital atherectomy, it has a high freedom from male at 3 years, major adverse limb effect, and improving the mean number of wounds within 30 days. Also, in highly calcified vessels like Rutherford 4 and up to 6, we can see still the success rate is 89%. Also in compliance trial, one of the famous trials that have 4,000, including more than 4,000 patients, we can see here the difference. The 50 patient heavily calcified femoral lesions, angioplasty versus angioplasty alone, and in 1 year follow-up, the patency was 80%. Also in Optimize, it's comparing the orbital atherectomy device and dark-coated versus BUBA plus dark-coated balloons. And the conclusion, as we can see here, that it's safe and effective procedure. Also here in this device, 3 years outcome of orbital atherectomy, we can see here there is marked improvement in freedom of major adverse effect. Also, there is freedom from major amputation, freedom from target lesion revascularization, and all causes of death. And here we can see the orbital atherectomy treatment for peripheral disease. We can see also the difference here that orbital atherectomy minimizes vessel damage and may reduce need for bailout stenting, with one of the main advantage for orbital atherectomy. So in conclusion, orbital atherectomy is working by a dual mechanism, which is bidirectional sending and pulsatile effective effect that may crack the calcium inside the elastic lamina and potentially improve the drug uptake. Plaque modification improves the vessel compliance and lumen enlargement, and it's approving benefits from symptom relief and improved limb salvage from CLI patients. Multiple clinical trials confirmed that there is a high procedural success rate, freedom of major adverse events, freedom from amputation, and demonstrated also value of orbital atherectomy. Thank you.